Good morning. I am Dr. Deepa, MBBS, MD in Pediatrics, and NNF Fellowship in Neonatology. Today, I'll be speaking about neonatal resuscitation. So, what is neonatal resuscitation program? It is a program wherein medical personnel is trained in a cognitive, technical, and teamwork skills to resuscitate and stabilize a newborn. 85% of the newborn which are born do not require any assistance. What does that mean? It means that the 85% of the newborn which are delivered by normal delivery or cesarean section, they cry immediately, they have a good tone, develop a good respiratory effort. Whereas 10% of them require tactile stimulation. So 10% of them may not cry after delivery. So they need a gentle tactile stimulation to begin a respiratory support and good audible cry. 5% of them require positive pressure ventilation, and as few as 0.1 to 0.3% require an extensive resuscitation, that is endotracheal intubation, cardiac compressions, and medications. So is NRP same as CPR? CPR is a cardiopulmonary resuscitation that we do in adults. What is the major difference between them? CPR is usually when an adult develops a sudden cardiac arrest due to cardiac arrhythmia, the blood supply to the brain reduces, leads to loss of consciousness. During this event, the amount of CO2 that is present in blood is normal. Hence, the primary support that has to be given here is a cardiac compressions, not the respiratory support. Whereas in a fetus, the respiratory function is carried out by placenta. So any antenatal event that affects the placental function leads to CO2 buildup in a fetus blood, further leading to acidosis. This acidosis affects the respiratory rate and the fetal heart rate. So fetal heart rate and respiratory rate can increase or decrease. So what is primitive here? Ventilation of a newborn's lung is a single most important effective step in a neonatal resuscitation. So in a team which is attending a neonatal resuscitation, one person has to be there who is a trained person in newborn ventilation. So this picture shows the fetal circulation where the oxygenated blood is carried to the fetus by the placenta. Hence, showing that the fetus received the oxygenated blood from the placenta. Whereas in a fetal lung, the alveoli are filled with liquid, where after the baby is born, baby takes a deep breath, has a strong audible cry. The fluid is replaced with air. So how a team has to know that baby has had and might need resuscitation, or what are the signs that baby did not have a smooth transition? The baby might have an irregular breathing or absent breathing, which is called apnea, or it might have a rapid breathing, slow heart rate or rapid heart rate, decreased muscle tone, pale skin that we call pallor, or a blue skin that is cyanosis. Once we attach a pulse oximeter and take blood pressure, baby can have a low oxygen saturation and low blood pressure. So before any team goes for a resuscitation or they get a call for resuscitation, any team which is trained for neonatal resuscitation, this whole chart is of the most important point. That is, any team which goes to attend resuscitation in a labor room or in a OT, they have to know their environment. That is, where is the room where the neonatal resuscitation will be conducted? What all equipments are there? Are the equipment functional or they need to be replaced? What is the temperature of the room? What is the temperature where the baby will be resuscitated? That is the warmer. All the available information, that is the mother's antenatal history or any antenatal complication, should be taken from the obstetrician and should be shared among all the team members. The plan after delivery, that the baby might have a complication, so the plan has to be anticipated prior to the delivery of the baby. The team member should be clearly identified as to what is the responsibility of each of the team member. Who is the team leader should be clearly identified prior to delivery of the baby. communicate effectively. So there is something called as closed loop communication, which I'll be dealing later. So the team members have to be trained in a proper closed loop communication for an effective quality resuscitation. Each team member should be given proper, should be designed designated a proper work to them in which they are already been trained, and all the available resources should be used effectively. And in case if the baby requires further resuscitation, as I already mentioned, that is ET tube intubation or a laryngeal mask or a chest compression, when additional help is needed, they should be called in time. And the whole of the procedure should be in a professional manner. There shouldn't be any verbal or non-verbal communication which does not, which is unprofessional. So the entire neonatal resuscitation is in this chart. So what I have done is, due to lack of time, I have divided the entire resuscitation into the four categories, and we'll be discussing depending on each category. So before we go to the resuscitation, before the delivery of the baby, the team member have to ask certain questions to the obstetricians. So what are those four important questions? One is, what is the expected gestation age? That is the baby term or preterm baby? If it is preterm baby, we know that we might anticipate certain problems and we have to be ready accordingly. Is the amniotic fluid clear or it is meconium stained? Or in certain situation, there can be antepartum hemorrhage leading to visible blood. Are there any additional risk factors? That is the mother diabetic, is she hypertensive, or any other complication in the antenatal history? And what is the umbilical cord plan? So what umbilical cord plan, are we going to cut and clamp and cut the cord immediately, or are we going for a delayed cord clamp wherein we wait for 30 to 60 seconds and after that we clamp the cord and cut it? There is no strict protocol as to how many members have to be there in a resuscitation team, but minimum of 4 have to be there, and one person has to be there who has been trained effectively in positive pressure ventilation. So we have already discussed this, that is after we have asked these questions, the whole team has to undergo a briefing, that they have to know their work, and each person should know all the history of the mother, and they should know what all equipments are present and how they have to use those equipments. So coming to closed loop communication, I already told that the behavior of the team members in the delivery room has to be very professional. So the communication has to be in a closed loop communication. That is, each team member have to know each of the team members' name. And when they communicate with each other, they have to make an eye contact and speak clearly. Whenever a person is giving instruction to the other person, it should be by taking their name, and the person who receives the instruction has to clarify that he has received the instruction. And after the work is done, he has to report back to the person who has given the instruction in clearly and loud voice. So the entire resuscitation program I have divided it into in these categories. One is uncomplicated delivery, wherein not much resuscitation of the baby requires. Second one will be delayed transition. Third is if the baby is apneic or if the baby is gasping. Next is a labored breathing, and last one is a most complicated one, wherein the baby delivers with a low heart rate or no heart rate. So what is an uncomplicated delivery? There we have asked the questions to obstetrician, that is the baby term or preterm, and is there any antenatal complication? Is the amniotic fluid clear or no? And what is the plan about the umbilical cord clamping? So here usually the baby will be term, the amniotic fluid will be clear, there won't be any antenatal complications, and with the obstetrician's help we have planned for a delayed cord clamp. So the baby is delivered, baby cries immediately after birth, it has good heart rate, baby has good tone. So baby will be delivered onto the abdomen of the mother for skin to skin contact. Meanwhile, when the baby is on the mother's abdomen, baby is covered, and the baby is just observed if the baby is having a good cry and good tone. After 30 to 60 seconds of waiting, the umbilical cord will be clamped and cut. So here, baby did not require any resuscitation. Baby had a very smooth transition to a postnatal life. So, and the next one is if the baby, the next category will be delayed transition. Here it is almost same as an uncomplicated delivery. That is, most of the times it is term, but it can be a preterm baby. Term as in if the baby has a poor postnatal transition, or if a baby is a preterm where they require certain assistance for postnatal transition. So baby can be term or preterm. Amniotic fluid can be clear, or sometimes it can be meconium stained. There might be any antenatal complications. And here we have planned for a delayed cord clamp. So what happens? Baby is delivered, baby has a good cry, baby is having good tone. So we shift the baby on, deliver the baby onto the abdomen of the mother. There baby is observed. We see that baby is having good cry, baby is having good tone, but we see that the baby is persisting to be cyanotic. And meanwhile, one of the team member will attach the pulse oximeter to the baby, and we see this is the this target saturation, oxygen saturation table has to be there in every place where wherever the resuscitation takes place. So we see that what is the time of the delivery is the oxygen saturation same as what is given in the table. Most of the time in a delayed transition, what happens that the saturation of the baby is less than what is required. Even if the baby is having a good cry, good tone, baby is a term baby, maybe the amniotic fluid is clear. In spite of all of that, here the baby become the saturation is less. So what we do, we just give free flow oxygen to the baby, or we give oxygen through a mask uh, till the oxygen saturation picks up. Once the saturation picks up, we slowly reduce the oxygen and remove the oxygen, and then monitor the baby for some time. So how much of oxygen are we going to give here? If a baby is more than 35 weeks of gestational age, we are going to begin resuscitation with 21% of oxygen. If it is less than 35 weeks, then we can begin with 30% of oxygen, and depending on the saturation of the baby, we'll change the amount of the oxygen that we supply. So how do we give free flow oxygen? This is a way of giving free flow oxygen wherein the tube is connected to the oxygen blender and the free flow oxygen is given to the baby, or through a mask. This is an T-piece resuscitator. Through the mask, it is just held away from the, slightly away from the face of the baby. It should not be kept on the face of the baby. Neither are we operating this T-piece. We are just holding it on to the face of the, just above the face of the baby. And the third one will be if at all baby is delivered with no respiratory effort, or that is baby is apneic, or if the baby is grunting. So what does apnea mean? The baby has delivered with no respiratory efforts. So when does this happen? This can happen in a term or a preterm baby. Usually, if it is a term baby, it has undergone any stress, then the amniotic fluid can be meconium stained, and there can be a history of antenatal complications. If at all we are anticipating that baby may not, maybe baby is delivered with a complication, then we do not go for a delayed cord clamp. We decide to see for if the baby cries, and if the baby doesn't cry, usually delayed cord clamp is not practiced as of now with the present evidence available. So what we do, we see if the baby is delivered, we see that baby is not crying. So what is done? Immediately the cord is clamped and cut. Meanwhile, when one of the obstetrician is clamping and cutting the cord, the other one gives a gentle tactile stimulation to the baby. Meanwhile, if this with gentle tactile stimulation, if the baby cries, it is well and good. We take the baby to the warmer and go ahead with the further resuscitation. But if at all baby does not cry, baby is shifted to the warmer immediately, and there we begin with the further resuscitation. So what all further resuscitation we do? We first try with the gentle tactile stimulation. So what is the tactile stimulation? We rub the back of the baby or the sole of the baby to stimulate the baby to cry. If baby does not cry here, then we have to immediately next go for positive pressure ventilation. So what is positive pressure ventilation? Positive pressure ventilation is giving respiratory support to the baby through one of the instrument, that is self-inflating bag, or an free flow bag, or an T-piece resuscitator. So with the present guidelines, it is advised to give this with an T-piece resuscitator. It is supposed to be the most effective one with with a less often complications, because with other two, what usually happens is the personnel has to be trained properly. The person should be knowing to know how much of an pressure has to be exerted. But with TPs, we are seeing here that we have the knobs to fix how much pressure we are going to give. So this last picture shows us how do we deliver it, or before delivering, we check for if the machine is working, if the TP is resuscitator, that is a neopuff, is it working properly. The mask is kept blocked on the palm of the medical person, and the top of it, that is, there is a hole, we keep blocking it. Meanwhile, when we block it, we see if the pressure is increasing here. In this, minimum pressure, that is PEEP of 5 is provided, and the PIP, the peak pressure, the max PEEP pressure can be delivered up to 25 to 30, depending on the baby's gestational age and the requirement by the baby. So the positive pressure ventilation, the other two, that is the self-inflating bag and the free flow bag, explanation is also there, but due to lack of time, I am not going in detail of these two. Present NRP tells that TP's resuscitator is the best, but if it is not available, then we can go with the other two type of resuscitation. So once the baby, we start with TP's resuscitator. To begin with, baby has to be in a sniffing position. This is called a sniffing position, wherein the baby's neck is extended, the mouth is open, and the baby's head is slightly elevated. We can keep a cloth below the shoulder of the baby, not under the neck or the head. So this is a sniffing position. Baby has to be given a sniffing position before, and then we keep the mask. There are two types of mask available. That one is anatomically modified, and one is a round mask. This is an anatomically adjusted mask, wherein the cone shaped is kept on the nape of the neck, on the nose, and the lower margin comes below the lower lip. Whereas the round one is just kept on the nose, covering, so that it covers the nose and the mouth of the baby. They have to be kept in such a way that there is no leak of the air from any of the corners in both the kind of masks. So mask is kept on the baby's nose and mouth. If required, if at all there is any fluid that is accumulated in the airway, then suctioning can be done. This suctioning is optional in any of the scenarios, no matter baby is having respiratory efforts or no, if baby is having good heart rate or no. In any of the scenarios, the suctioning of the baby's mouth and nose is always optional. It is done only if the secretions are blocking the airway. Why? Because while suctioning, we might stimulate the vagal nerve and then lead to further bradycardia. Hence, it is done only when necessary. So the mask is kept in position, and then we start with the positive pressure ventilation. Positive pressure ventilation is given for 15 seconds, and then we see for an increase in the heart rate. Most effective sign will be the increase in heart rate. If at all heart rate is increasing, saturation is increasing, we continue till the baby develops a good audible cry, and then we see if it can be stopped. But if at all it does not happen, baby does not develop a good respiratory effort, then we have to go for MR SOFA. What is MR SOFA? Where M stands for mask adjustment, R is for repositioning of the head and neck, S is for suctioning of mouth and nose if necessary, O is open the mouth, P is pressure increase, and A is alternative airway. So this has to be done to see if we are doing something wrong. Once all this is done, again we give positive pressure ventilation for 15 seconds. Again, we have to see the chest rise, see for increase in heart rate and saturation. Once all this happens, the baby's heart rate is increasing, saturation is increasing, baby develops a good audible cry, then we can slowly stop the positive pressure ventilation and then start the baby on oxygen. Meanwhile, oxygen saturation is checked. See how is the baby breathing? Is the baby having grunting? If at all baby is having grunting, as in it can happen with many preterm babies, then delivery room CPAP can be started. Delivery room CPAP is out of the scope of NRP here, so I'll not be dealing with that in detail. Okay, so after after the positive pressure ventilation, this again, here also the oxygen saturation for a term baby will be for more than 35 weeks will be 21%, less than 35 weeks will be with the 30%. So how are we going to hold this mask? There is something called C and E way of holding the mask. This C is one thumb is on the near the nose, the index finger is near the lower lip, and E is on the jawline. This technique is of holding the mask is so that we prevent any air leak. If at all we cannot do it with this way, then we can go with two hand, where one person is holding the mask by both of his hand, and the other person will be giving the positive pressure ventilation. Throughout this, the team leader has to monitor how the medical personnel is providing PPF, and if at all any changes are required, he has to immediately tell it there and then and has to get it rectified. So next one, if at all even after giving an effective positive pressure ventilation with the TP's resuscitator, the baby's heart rate remains less than 100, or even after a properly trained, properly corrected way of giving PPF, baby does not develop a spontaneous respiratory effect, we go for ET tube intubation. ET tube is endotracheal intubation, where a tube is inserted into the trachea below the vocal cords, and through that the positive pressure ventilation will be given. Who has to do this? If such a scenario arises, then the person who is trained in this should be called immediately, and that person has to perform this procedure within 30 seconds. So what happens? What are the questions here? Before the delivery happens, most of the times it can be anticipated, as in baby might be very preterm, or the amniotic fluid can be meconium stained, where the baby's heart rate is antenatally when heart rate is fetal heart rate is checked, the baby can be having bradycardia, baby's movement can be reduced, the stress test reports can suggest that baby is under the stress. So all this scenario tell us that the baby might need a good amount of resuscitation. In such a scenario, the team member who does an endotracheal intubation should be kept informed and should be readily available. So here, if even after PPF is provided, heart rate does not increase above 100 and baby does not develop a spontaneous respiratory effort, the baby will be intubated with a ET tube within 30 seconds. So how the ET tube should be kept ready in the room, as we have already discussed it before. Different size of ET tubes will be available from 2.5 to 4. Very rarely, ET tube of size 2 may be needed, as in when the baby is very preterm, or if there are any anatomical defects, it can be needed. Laryngoscope should be ready, which is working with good illumination. Next is the blade size of 0 and 1 should be ready. 0, 0 also should be kept available, and stillet should be there. So all these instruments should be checked before delivery of the baby and should be kept ready. Once the person intubates it, before that he has to know what amount of length should be intubated. So there are multiple ways of knowing what should be the depth of endotracheal tube intubation. That there are multiple ways, that is through a nasotracheal length, or the tube come with marks on that 2 lines. So the distance between them is the place where it should be fixed, or there are multiple formulas. But many a times these may not be accurate. Hence, once the tube is intubated, we confirm the position by auscultating an audible and equal breath sounds in bilateral axilla, or by calorimetric CO2. And last, by an chest X-ray. Once after the ET tube position is confirmed, it should be fixed in place by an waterproof tube. After the tube waterproof tape, once the tube is fixed in position, it can be connected to a TP's resuscitator or a self-inflating bag for further resuscitation. Once the tube is fixed, after that, we know that tube is in position, it has been fixed. After that, if the baby deteriorates, we have an acronym called DOPE to rule out what might have gone wrong, where the D stands for tube might have got displaced, O is for obstruction of the tube, P is for pneumothorax, E is for equipment failure. So if suddenly baby deteriorates after the intubation, then we have to go ahead and see and rule out DOPE and see what has gone wrong. and then again continue with with resuscitation. So the resuscitation, after the intubation, we continue with the resuscitation with TP's resuscitator or an self-inflating bag, and check for increase in the heart rate and increase in the saturation of the baby. If at all the heart rate is increasing, the saturation is increasing, we continue with same endotracheal ET tube resuscitation. If at all baby develops a good respiratory effort and baby's activity is good, the muscle tone is good, in the labor room only the ET tube can be removed, and then further support can be respiratory support can be given to the baby. But in a scenario where even after proper endotracheal intubation resuscitation has been done, the heart rate of the baby does not increase, baby's tone does not increase, and baby's saturation does not increase, then we have to go in for the next step, that is chest compressions. So when the chest compression has to be given, chest compression has to be given if the heart rate remains below 60, even after a proper positive pressure ventilation has been done for at least 30 seconds. Proper, that is with good adequate chest rise, good pressure, and with a trained personnel. Even after that, if the heart rate remains below 60, then we go ahead with chest compression. In most cases, we know that ventilation, if at all it is properly done with the ET tube and laryngeal mask, then the baby's heart rate usually improves, and the further resuscitation can be continued without chest compression. But in some cases, wherein antenatally baby has suffered a lot, it has faced loss of a lot of antenatal insult, then the heart rate might be less than 60 and the chest compression becomes mandatory. During chest compression, the amount of oxygen supplied will be 100%. It is not, we do not apply a formula of 21-30. Here it has to be 100% oxygen. And the chest compression rate will be 90 compressions per minute and 30 breathing. So to maintain this 90 to 30 ratio, we have a rhythm, that is 1 and 2 and 3 and breathe. So the person who is doing chest compression has to tell it loudly, that is 1 and 2 and 3 breathe, 1 and 2 and 3 breathe. So to maintain a proper chest compression and ventilation cycle, each chest compression and ventilation cycle usually lasts for 2 seconds. That the time taken for this will be 2 seconds. That it tells us that the amount of the way we are resuscitating is correct. Where is the place? There are two ways of giving chest compression. One is with 2 thumb and the one is with 2 finger. The 2 thumb technique, that is this one, is the better way of giving chest compression. The person who is giving chest compression should obviously be trained in that and should be conscious that he is not harming the baby while doing this. That is, there should not be any injury through his nails. The nails should be trimmed. He should be providing the exact amount of the pressure that is needed. There should not be any damage to the rib cage of the baby. So where is the location where the chest compression is given? It is at the lower end of the sternum and just above the xiphoid process. So how much of the compression, what should be the depth of the compression? That should be 1/3 of the AP diameter of the chest of the baby. So that means the amount of the pressure that is exerted is sufficient. So after the 60 seconds of an coordinated chest compression and ventilation, we see for the change in the heart rate or change in the saturation. We do not see it before 60 seconds. Why? Interrupting it every now and then leads to failure of this proper cycle. Hence, we have to provide it for 60 seconds and then check for an increase in heart rate and saturation. Once the heart rate increases above 60, then the chest compression can be stopped and endotracheal resuscitation can be continued. Even after doing it properly, if at all the heart rate is not increasing, then we have to see for the quality of the compression and resuscitation that we are doing. So there is a mnemonic for that, that is cardio. So C stands for chest movement. Are the chest movement adequate with each respiratory support? The movement of the chest is adequate or no? The chest rise is present or no? Airway, is the airway in position? Is it secured or is the tube got displaced? And if the rate is same, that is with every 3 compression, there is 1 ventilation and the time is 2 seconds. The depth should be 1/3 of the AP diameter and the amount of oxygen supplied is 100%. So we check for cardio, and if all of this is correct, and then again we continue for next 60 seconds of resuscitation, and then check for increase in heart rate and saturation. If at all, even after a proper 60-second resuscitation, the heart rate of the baby does not increase above 60, then this is a scenario where the medications come into play. So what medications do we use? We give epinephrine. So how is epinephrine given? Epinephrine is given either through intravenous, that is through the umbilical vein, or through intraosseous. Many scenarios are there where it is given through ET tube, but present NRP does not recommend ET tube adrenaline. It is better to put an umbilical vein. The umbilical vein will be catheterized with an umbilical catheter. There is a formula to know how much it has to be inserted, but in a labor room, what we can do is insert it as long as we get a free flow of blood. So keep it in that position and give adrenaline through the umbilical vein. There shouldn't be any attempt made to put an peripheral venous line. It is not a situation where we put a peripheral venous line and then give through it. So it is totally not recommended. It should be through the umbilical vein or an intraosseous line. So amount of the dosage that is given will be 0.01 to 0.03 mg per kg of adrenaline. And how much is it, how many times it can be given? It can be given once in every 3 to 5 minutes. It should be pushed. It is not a slow infusion. It should be rapidly pushed, and following that, a NS push has to be given. So we give adrenaline and then again continue with 60 seconds of resuscitation, and then check for heart rate and saturation. If heart rate has not improved, again then repeat. So this can be repeated every 3 to 5 minutes. So how many times it can be repeated? There is no clear-cut guidelines as to how many times it can be given, how many times it can be repeated. We usually give up to 3 times. Next, even after the adrenaline has been given, we see that baby is not improving. There are signs of shock, and there is an antenatal history that mother was bleeding prior to delivery. In such a situation, we go for volume expansion. Volume expansion. So what are these? What do we use? One is normal saline or R negative blood. So in the labor room tray, normal saline filled syringes should always be ready, or O negative blood has to be ready if at all we anticipate that the baby might need the blood. So the normal saline syringes have to be ready in the OT, in the labor room, and it should be given again by intravenous or intraosseous. It is given as a bolus of 10 ml per kg at the rate of we push it over 5 to 10 minutes. So how many can be given? Again, as I told, as in adrenaline, three times it can be given. So again, there are no guidelines as to how many times it has to be. After it can be given. After each bolus, we check for increase in heart rate. If at all heart rate is increasing, the volume is good, we stop with the boluses and continue with the resuscitation. This is again the same volume expanders, how it can be given. If at all the baby is a preterm baby, then we need to be careful with the amount of the boluses that we are giving. We shouldn't be overloading the baby, leading to further complications. Even after all this resuscitation, if the baby does not develop a heart rate or the heart rate is less than 60, so what happens in such a scenario? So usually such babies do not survive, but if at all they survive with a significant neonatal morbidity. Hence, in such a scenario, the treating doctor, that is the team leader, has to take a decision after discussing it with the parents of the neonate. The scenario has to be discussed with the parents, and then we decide if the resuscitation has to be continued or stopped. The parents have to be told clearly that if at all the baby survives, then the chance of neonatal morbidity are very high. Are there any scenarios where the baby survived without any neonatal morbidity? Yes, there are scenarios, but the chances are very less. And if at all the baby's heart rate improves, then the postnatal resuscitation care has to be given. So what is this postnatal resuscitation care? Postnatal resuscitation care includes the baby's respiratory support to be continued with the ventilator requiring, depending on how much of the pressure it requires. And then what is the oxygenation that is required? baby should not be hyperoxygenated, nor should be the oxygen supply limited, because both of them have the equal their respective brain damages. So the blood pressure of the baby has to be monitored, and required inotrope support has to be given. Baby's blood glucose should be monitored. Baby can have hyperglycemia or hypoglycemia. Hyperglycemia is usually stress induced, followed by hypoglycemia, and the electrolyte imbalance due to so much of significant stress that the baby has undergone. It can have hypernatremia, hyperkalemia. So the electrolyte should be monitored. Urine output, baby should be catheterized. Invariably, each of these baby have to be catheterized, and the urine output has to be monitored. If the urine output is less than the required, renal support should be given to the baby. Neurological status, that is, if the baby developed seizures, or if the baby's neurological status that which is assessed with the EEG should be noted. If the continuous EEG pattern is flat, then such an outcome of such an baby is very poor, and same has to be informed to the parents. Most important one that I have mentioned at the last is the temperature that has to be maintained in the neonatal period. Why? Most of the time when we are resuscitating, we keep that the warmer is on and the probe is connected to the baby so that the baby doesn't get overheated. But here, if the baby has not cried for such a long time and required resuscitation, these babies might need hypothermia treatment, that is therapeutic hypothermia. So there is a concept that in the labor room, the warmer might be can be kept off. The warmer need not be on, like in every case that we follow, that the temperature we maintain. But here the warmer can be kept off in the concept of therapeutic hypothermia. And once the baby is shifted to the labor room, therapeutic hypothermia has to be started to prevent the amount of the brain damage that is going to happen in the further coming hours or days of the baby's life. So any neonatal, any hospital that is dealing with the cases of such severity, they have to have a therapeutic hypothermia treatment in their hospital.
Doctor, sorry to interrupt. We have less than a minute.
Oh, sorry. This is last slide. There are certain considerations, a special situation, myelomeningocele, CHD. And in CHD, we don't give positive pressure ventilation by mask. It has to be intubated. So there are other scenarios where each one of them is a class in its own. So I have just mentioned the names of this. Thank you.